Thank you. What are your what are your thoughts? Anyone can kind of jump in. Anyone want to share what they think of the video or what they thought of the video? No? Okay, I'll move on. Oh, sorry. In the chat, you have tears, yeah. So the first time I saw this video, yeah, I responded the same way. It really teared me up. I was quite sad and moved, and it meant so many different things to me. The reason why I share this video is because quite often the youth that we work with, Black neurodiverse youth, are instantly and instantaneously labeled. And those labels stick. So whether that's education, that's healthcare, and social environments, those labels stick. And those labels definitely have, they're what we call designated labels, and they have an impact on them that is not felt or experienced by folks who are not Black and neurodiverse. So just something to think about. I'm going to continue with my presentation. If I could just share. Keep those comments coming in the chat. All right. Something to think about. It's not homework or anything like that, but as you're thinking about the video and what happened and how it resonates with you, think about how you identify yourself and what are some of the more obvious and less obvious things about you that are part of your identity. And just in thinking about designated labels, how they get kind of placed on people, it's involuntary. It's not like, as you saw in the video, it's not like folks are walking around asking for these labels, but just based on observation and based on behaviors and based on people centering their own values and beliefs, these labels are stuck on others. A little quick reflection as well that you might want to do is just thinking about the differences between a designated label and an autonomous label. So this is extremely important to Black neurodiverse youth, are labels that they carry themselves, that they have either adopted or created, and they self-identify in specific ways versus, again, designated labels that are kind of stuck on them and stick with them. So my question to you is, again, put it out in the chat room, or you can go ahead and just, you know, unmic yourself or unmute yourself, sorry. What's your working definition of disability? Because that's at the heart of who Yage works with, who we work with Black and racialized neurodiverse youth and young adults. And for some people, neurodiversity is not a disability. So I would say that maybe you can share your ideas on what you believe disability is, or how you define it, how you recognize it in other people, a little bit about the history of racism and ableism in healthcare in general. So how did we get to these words like disability and disabled, and how did ableism kind of come about? Well, it's really rooted in eugenics. And so I'm not going to give you a eugenics lesson today, but please do look it up, and please do look up Mr. W.E.B. Du Bois. So basically, eugenics is the, scientific proof, putting that in quotes, that people who are different from the folks who are white, cis, typically male, are deficient. And so disability really was a synonym for being deficient. And back in the day, they actually used the color of your skin to describe or to define what a disability is. So being a Black person was considered a disability, in the way that you were considered to be less intelligent. You were considered to be less capable and less able of doing things simply because of the color of your skin. And so ableism is really about centering the able mind and body. And I put that in quotations as well, right? So if you think about how we define disability and how disability is compared to or derived from the center, and the center happens to be, folks who don't have a disability. But then we got to ask, well, as healthcare workers, are you seeing people who mostly have disabilities or don't have disabilities? Have you worked with anyone so far that has a disability? What about the folks who have disabilities that don't want to share that information? I'm going to just stop sharing very quickly to show you a very small, super teeny tiny study that we did. I won't even say study. It was more like, a community consultation that we did with a community health center. We wanted to find out what healthcare providers understand about neurodiversity, understand about racism, and how it impacts their practice. And so most of the folks that we spoke to, they were direct care providers. Some folks that we spoke to were administrative folks. We asked them things like, how familiar are you in terms of disability language and health equity language? Have you heard the term neurodiversity before? Have you heard the term ableism before? What do those things mean to you? We also asked things about, how racially diverse your patient, group is, or how neurodiverse your patients are, your patient population. And folks kind of struggled with that. And there may be a few reasons for that. One being that not everyone who is neurodiverse wants to reveal that they are neurodiverse because they've had negative experiences in the healthcare system. I'm going to just stop here and move on. Does anybody have any suggestions or ideas around how we can combat ableism and racism? How does that work? Any ideas about that? What have you experienced, or what does anyone wish to share what they've kind of encountered? No, y'all are a quiet group. Wowzers. Okay. All right, I'm going to skip ahead a little bit. So the challenge here is that healthcare professionals don't feel comfortable having discussions around racism and ableism. They're not prepared to kind of recognize, okay, what are the things that would be helpful for me to support someone, to care for someone in an equitable way, if they are Black and if they are neurodiverse, if they have other disabilities. And so the first step really is thinking about difference and understanding the historical context of eugenics and how that plays into the healthcare system. It also may mean just, thinking about your personal beliefs, the language that you use, how you document. So if someone were to take a look at your documentation, would it have justice-laden language? Would it be equitable? Or would the person that you're speaking of, would they feel uncomfortable, reading what you've written about them? And I'm sure that you're getting a lot of information and education on that. Some direct impacts in terms of designated labels on Black neurodiverse youth. Folks feel that there's a presumed incompetence. They have poor access to care, as well as provisions of care are also, less than their counterparts who are not Black and not neurodiverse. Informed consent is not, how informed is it? So if you are aware, or maybe even not aware, that one of your patients is neurodiverse, are you, providing explanations that are meaningful and relevant to them, or are you just going through the motions? Because what happens is folks don't want to seek healthcare services because they experience trauma, fear, dependence. They have to mask a lot, so they have to pretend to be as non-neurodiverse as they possibly can in those settings. And then there's also the potential for medical errors. So if you're not explaining things well, and you're not explaining things in meaningful ways and in relevant ways, you're not using assistive devices, um, you're not communicating in ways that are relevant to your patient, there is that potential for medical errors for sure. So just to wrap up very quickly, I know I'm running out of time. Some neuroaffirming approaches to care that you can adopt in your own practice. Think about whether or not you're trying to change the person, the environment, or the behaviors. And one of the best answers is the environment, right? So you don't want to change someone. That's not your job. That's not the goal, especially when we're talking about neuroaffirming practices. Setting goals collaboratively, not being imposing. So although you have tasks to do and you have things that specifically that you have to get done, it has to be, explained in a way that really does mean and represent informed consent, true informed consent. Always think about the other person, your patient's autonomy, and how you can self-empower that person in those moments that you're with them, you're caring with them and caring for them. And of course, meet folks where they're at. And if you get trained, or if you have the opportunity to learn more about trauma-informed practice, I would strongly suggest that you do so. Last but not least, taking care of yourself, some quick tips. Gratitude. It's all about your perspective. So, at the end of your shift or during your shift, be thankful, grateful for the things that you do have. The positivity there will help. When you get home, make home your home sweet home if you can, if you have the privilege of doing so. Create some kind of routine when you get home. Print out photos that make you happy and remind you of happier times. And then of course spend time with people and mentors and other professionals and other students who you can shoot the breeze with, and you can get ideas from and exchange experiences with. Yeah, that's pretty much it for me. Does anyone have any questions?
We'll open up the floor to questions right at the end. But thank you so much, Carolyn. That was really, really insightful. Thank you for sharing your presentation with us. So our next speaker is Dr. David Green. So Dr. David Green is an assistant professor at the Brescia School of Food and Nutritional Sciences at Western University, and with a PhD in family relations and applied nutrition from the University of Guelph. And as a registered psychotherapist, Dr. Green has extensive experiences in teaching, research, psychotherapy, and community engagement. His research focuses on family dynamics, parenting, fathering, emerging adulthood, relationships, and mental health. And with numerous publications in esteemed journals, we welcome you, Dr. Green, and we're really excited to hear your presentation.
Good afternoon, and thank you very much, Danielle. Let me see how quickly I can get through this so we can make up on some time, so we have enough time for questions at the end. Somehow this is pretty ambitious in terms of what I wanted to accomplish in terms of objectives. I will try to see how we can somehow tie this together as nicely as possible. I want to start with some kind of historical context as I seek to address the specific focus of Black families in Canada becoming so successful and sustainable. So what we know is that we exist in a context with the historical baggage of slavery. And that has significant implications for how we navigate and move forward. Because what we know is that slavery is the critical operationalization of racism. So slavery was not just something that came up out of nothing, because other nations were enslaved before in different ways. But this kind of operation of slavery within the Black community uh, runs very deep and has created many challenges historically. We know that slavery created segregation, and segregation as it relates to the separation of Black and white. And this is deeply rooted in historical practices of systemic structures that emerged from the institution of slavery. And what happens when there is segregation of communities and there are scarce resources, those who live together in those challenging areas end up have to compete for scarce resources. And that now create challenges for them as it relates to how they relate together. So how Black people relate together is a part of this segregation and the pressures that it puts on the Black community. So we have systemic racism, quite a number of concepts, which permeates various institutions today, justifying the marginalization of Black people and creating more and more challenges. And you have institutional racism as well, which deals with specific policies and practices within particular institutions, creating unequal treatment of individuals based on race. So there are practices within institutions that systemically does this. So for example, if you have been following the news in Ontario, the report as it relates to how the public sector employees have been treated over the years. And now even at the federal level, there has been a Black class action suit as it relates to how the federal government has treated Black people over the years. And then we have structural racism, which has to do with specific policies and practices within particular institutions, creating unequal treatment of individuals on the basis of their race. And then structural racism, which is the interconnections between various societal structures that create and maintain racial inequality. So over time, we have these issues to deal with. And in more recent time, there has been the term environmental racism. And one of my colleagues, Ingrid Waldron at McMaster University, has been doing quite a lot of work on this, coming out of her work at Dalhousie University, which she has continued to do, also advocating for policies in terms of, how things are placed in communities, how the water has been affected, and how that creates other challenges, which are associated with the economic disadvantages that we continue to face as a result of the lasting negative impact of slavery on the wealth distribution and social mobility of Black people. This is also connected with the social determinants of health that we are very much familiar with, those specific conditions in which individuals are born, they grow, they live, they work. We are talking about a number of factors that we need to pay attention to that are creating challenges. So the neighborhoods in which we live, the education that we have, the economic resources that we have, the employment that we have available. And then the structural determinants of health, which we are talking about those broader social, economic, and political systems that create and maintain inequalities in health, affecting us in ways that are sometimes very challenging for us to navigate. So these determinants include the policies, the laws, and the institutional practices that stratify populations based on factors such as race, ethnicity, income, and education, determines what kind of resources are available, what kind of support systems are available, and so on. I want to transition then quickly to how can we empower the Black community in terms of economic empowerment, which is a very important part of what needs to take place. So we have to focus on the importance of economic sustainability. And economic sustainability can be facilitated in many ways, so we can become financial independent. We are talking about education and skill development, entrepreneurship and business development, financial literacy. So, for example, what is interesting is that it is possible to go through an entire secondary and post-secondary education without any training in financial management and understanding how money works. To add to that, sometimes we are told it's okay to file our own taxes. We don't know the laws and what we are supposed to be claiming. So sometimes there are benefits that we don't even make use of because we don't know that those benefits are available. How do we access capital? And how do we create systems within the community where we support each other in ways that can allow for capital to be generated for ventures that need to be developed and put in place. Addressing systemic barriers, community support and solidarity becomes a part of that, and addressing health and well-being as economic factors. So, for example, what we know is if we're not doing well mentally and physically, it means we will need days off from work. When we have days off from work, it becomes more difficult for us to make progress in our work in terms of promotion and in terms of how we are viewed, in terms of contributions that we make. And then how can we leverage technology and innovation so that we can look towards remote work, gaining other opportunities for employment online, business development online, and so on. I will move on from there and talk a bit about education and career development, because this becomes important in terms of how we break the generational cycle, the cycle of poverty. What we know, for example, is that when immigrants come into Canada, they tend to focus a lot on education and try to advance in terms of education, but then their children seem not to do as well as they have done educationally because of how the system seems to work against them and discourage them. So how can we ensure that we promote education as important in breaking the cycle of poverty? How about promoting sustainability through different avenues and techniques to make sure that individuals feel that they are empowered to do what they want to do? So, for example, what we know in terms of immigrant women versus Canadian-born women, those who have education in Canada are more likely to be in full-time employment. So those without Canadian education are more likely to be in precarious employment, or what we refer to as gig work. So what we want to do is to promote the need for tertiary education. Matter of fact, at least at the bachelor's level from the studies that I have reviewed. Initiatives and programs that support educational attainment and career advancement become very important in that whole scheme. I want to talk briefly then about health and wellness, because we know that there's health disparities, that Black people are more susceptible to certain diseases and health conditions. By the way, some of this is actually associated with how food is prepared in Canada versus how food used to be prepared in country of origin. And some of those differences make a big difference as it relates to longevity and how health is supported. We also know that it is important for us to focus on mental and physical health in achieving sustainability. So health and mental health awareness become a very important part of what needs to happen. So for example, in a study that we conducted recently in Hamilton, that focus on Black youth access to mental health and other services. One of the challenges that they face had to do with their awareness of, for example, mental health, given the discrimination that is associated and the bias that they have to deal with as it relates to how they are treated in the healthcare system. There needs to be access to culturally sensitive health and mental health care. Going back again to the study that I mentioned, it is important for services to be provided in culturally sensitive ways. And also, persons indicated that they are more likely to show up for mental health treatment if it is offered by persons who identify with their cultural background. And then we need to talk about healthy lifestyle choices, what we do on a daily basis. So move away from the concept of dieting to talking about lifestyle changes, and we can talk about those differences as we progress. And then the importance of community support, because what we know is that the various kinds of social support is a very important part of how we can make progress. So we are talking about informational support, tangible support, esteem support. We are talking about social network support and emotional support. And we can go on as it relates to other dimensions that might be important. And then the importance of culture, community and cultural identity, that persons want to be able to feel comfortably in their own skin. And sometimes the context makes it difficult for that to happen. How can we continue to promote that through the kind of community support within our organizations, within the cultural practices and the social networks that we develop? So, for example, it is interesting, very interesting, going back to the study I mentioned, that individuals mentioned that, for example, dance is an important part of how the Black community express themselves and can be a very important source as it relates to how mental health can be handled. But in a lot of the communications, we don't talk about music and dance as a part of how we socialize and can help us to overcome. We have to talk about policy and advocacy and the difference between public policy and social policy, and ensure that we're advocating for these policies that are very supportive to the Black community. And finally, we have to talk about how we can achieve success and sustainability. And one of these things that can be very helpful is asking the question, of ourselves: what are our experiences of Black excellence, and how can you or how can we replicate Black excellence? I will stop here for now so that we will be able to get the other presentation and go into the questions. Thank you very much.
Thank you so much, Dr. Green. That was wonderful and very insightful. We'll next welcome Dr. Cornel Greay. So Dr. Cornel Greay is an assistant professor in the Department of Gender, Sexuality, and Women's Studies at Western University, and his research focuses primarily on the health of Black queer men. More specifically, he is interested in the ways that Black queer men mobilize skin-to-skin contact as a practice of care. And his current projects include a qualitative study examining the impact of positive touch on the health of Black queer men, and an archival study examining Black queer diasporic networks. So welcome, Dr. Greay.
Thank you, Danielle, and thanks for the invitation. It's a real pleasure to be sharing some preliminary, findings of a project I've been working on for a few months. Also, really great to be sharing space with David and Caroline as well. So let me see if I can pull this up here. Okay. See if I'm doing that properly. Okay, I'm assuming it's visible. My screen's doing weird things.
Yeah, we can see it.
Okay, perfect. Thanks. Okay, I'm trying to figure out how to do. I can't see the full screen thing in my window. Just a sec. Okay, is it still full screen on your end? I'm hoping.
Perfect. Yeah, it's full
Yes.
screen.
Okay, perfect. Great. Thank you. All right, so I'll try to be brief. So the work I'll be sharing today is from an ongoing project that I'm working on called the Skin to Skin study. I guess just a bit of background that might help orient folks. I completed my PhD during COVID, and part of the project was thinking about Black queer intimacy and feeling and connection. And the question of contact and connection became quite prominent during lockdown because obviously people weren't or couldn't be in proximity to each other. And I started to think about some of the consequences of that, but also thinking about, how did Black queer communities navigate touch, connection, intimacy, even during the AIDS crisis as well. So that is a kind of a point of departure for the project that I'm working on today or talking about today. So just a bit of, I guess, high-level overview. Despite efforts to regulate the sexual practices of Black queer men through the promotion of HIV prevention strategies or technologies like condom and pre-exposure prophylaxis, relatively little is actually known about the motivations and decision-making that inform Black queer intimate practices. There are a lot of questions about what Black queer men do when it comes to their sex lives, but very few people are actually asking people, what do they want? What do they desire? What does sex actually mean to them? It's a very kind of like more of a clinical approach in most cases. Researchers working at the intersection of Black queer studies and public health have, however, more recently provided more insight into the sexual lives of Black queer men. However, much of health science scholarship has not fully examined condomless penetrative sex as a subset of tactile practices meant to maintain the physical, mental, and sexual health of Black queer men. And what I'm saying that is, there's often a push to demonize people or, berate people for not, let's say, using condom or going on PrEP. But again, there aren't necessarily ongoing questions about, okay, well, why are Black queer men in particular making some of these decisions? Okay, let me just skip to, all right. So studies that focus on the impact of touch deprivation on a person's health rarely speak to the experiences of Black people, let alone how anti-Black racism prohibits access to positive forms of touch. And so the Skin to Skin study is trying to respond to current knowledge gaps in Black queer men's health. The purpose of the study is to collect data on the social and sexual practices of Black queer men in Ontario to understand the role of skin-to-skin contact in their lives. Doing so will help us to develop culturally responsive approaches to support HIV and STBBI prevention in Black queer communities that account for the varied health needs and priorities of this population. And so in collaboration with community members, this work is also trying to identify and examine cultures of care among Black queer men in Ontario to develop some kind of wellness model that recognizes the material need for touch. So scholarship has also shown that positive forms of touch release oxytocin. Known as the happy hormone, oxytocin has been found to contribute to social bonding and improved mood. More generally, skin-to-skin contact supports a healthy operation of bodily functions like sleep, digestion, heart rate, and lung function. Loneliness has emerged as a common symptom of touch deprivation and has recently been referred to as an epidemic. COVID-19 prevention guidelines, so social distancing, isolation, and so on, have exacerbated this problem. Healthcare providers have even warned that Healthcare providers have even warned that COVID-19 prevention interventions and the stress of the pandemic could result in an increase in suicide. Loneliness and social isolation pose a risk to Black queer men's health, particularly those who are elderly and or live alone. Throughout the COVID-19 pandemic, public health policy has effectively marked physical contact with individuals outside as one's household as dangerous to a person's health. And so for Black queer men living with HIV, the situation is particularly acute. Even though people living with HIV can now have condomless sex without risk of HIV transmission, misinformation and stigma against people living with HIV may result in limited access to positive touch in Black queer men's social and sexual lives. HIV stigma also affects people who are not known to be infected, but may assumed to be such, based on discriminatory narratives about their communities. And here I'm thinking about queer folks, of course, and Black folks. So I'll get into a little bit of the data now. All right, so I guess I talked about the objectives of this debate. So interviews took place between October 2023, September 24. I was able to get 31 interviews done. 32% of participants are living with HIV. There's an age range of 21 to 59, with the average age being 36. And among HIV negative men, 43% reported PrEP use at the time of the interview. 74% of participants identified as gay, and then others would say that they're queer and gay, pansexual, or in one case, someone chose not to respond to that particular prompt. All right, so just a few quick highlights here. Oh, okay, there we go. All right, so I asked participants about, how is physical intimacy between men talked about or received or perceived in their particular communities. Many of the men that I spoke to are immigrants to Canada. And so there were other participants that were talking about, and I mean, this isn't specific to, like sex necessarily, right? It could even be something having to, do you see men hugging or like holding hands, generally speaking? And so for this one participant, he said that for him, people in his community thought it was quite disgusting. In some cases, people would think that that person was, being possessed and, some kind of intervention was required. So many of these men grew up being told in some shape or form that any kind of physical intimacy, connection, physical contact between men is inappropriate or abominable in some way. Oh, there we go. Okay, so another participant, is talking about his experience being in Canada. So I was asking folks, well, based on where you are now, how comfortable are you engaging in like physical affection or physical intimacy when you're generally on the street, right? This particular participant says that there's an assumption that Canada is supposed to be safe, progressive, multicultural, inclusive, all of these things. And yet for him, he's still quite scared about engaging in potentially holding a partner's hand when he's walking down the street. And so, I thought this was quite important in kind of troubling, these commonly held assumptions about what life is assumed to be like for queer people in Canada. I also asked folks, well, are there specific areas that you might feel more safe or less safe? Some folks would say, well, they don't feel comfortable expressing or talking about their sexuality in, let's say, workspaces. If they are, let's say, downtown Toronto, specifically in the gay village, they'll feel more comfortable there, but people are actively making calculations about the areas in which they feel comfortable expressing themselves. All right, so this other participant, I was asking them about, well, how do you think your HIV status has affected your ability to access physical or sexual intimacy with other men? And this particular participant states outright that, usually when he discloses his status to other people, they'll say that they are no longer interested. And this was a fairly common response, unfortunately. So again, we have all of these, widespread information, these attempts to engage in sexual health education about risk of HIV and undetectability, and yet there's still this profound stigma within the queer community around who is considered desirable or quote unquote safe based on one's HIV status. And in some cases, I'll say, and this isn't necessarily specific to HIV, but depending on when some participants received positive test results, they were also experiencing, how do I put this? Some degree of discriminatory behavior with even health providers, which I thought was quite surprising. All right, so one of the things that I was, and maybe I shouldn't have been shocked about this, but most of the participants that I spoke to were surprisingly a bit shy about talking about what they liked or enjoyed or what they wanted. And for me, it was a reminder that, these aren't questions that Black women are invited to talk about very often. And what was also surprising to me was when I was asking people about the kinds of things that they enjoyed or desired, very few of it actually had to do with sex at all. Most people were looking for some degree of intimacy, right? The actual act of intercourse was secondary or tertiary in some cases. What people were largely looking for was connection. So this participant is talking about, well, he wants care, he wants company, he just wants someone, I don't know, to sit on the couch with him and enjoy each other's time. And that was a common motif throughout the interviews, which I thought was quite important. And so one of the things I'm, trying to think through at the moment is, well, how can we develop, I don't know, systems of care or cultures of care that build on a kind of platonic intimacy, because a lot of the participants, yeah, there are cases, for example, where people would only seek out sex in pursuit of a certain kind of connection, but sex wasn't their kind of like primary objective. And so are there ways for us to maybe find ways to engage each other to access that kind of intimacy outside of these kinds of sexual encounters? So those are a few quick highlights. I think I'll leave it there for now for the sake of time. Hopefully I haven't gone over or too much under, but
No, that's great.
yeah.
Thank you. Thank you so much for sharing your fascinating research. It's so needed and really important. Thank you so much. So I will now open up this series for a panel discussion. So if you have any questions for any of our speakers, please feel free to type them in the chat and I'll do my best to monitor them. Let me just open up the chat here. Okay, and I will also kick it off with the first question. I'm open to all of our speakers today. So one of the things that I think all of you talked about was masking and stigma. And so these were mentioned in different ways in each of your presentations. One of the things I wanted to ask about was how can we ensure that individuals feel comfortable in expressing their own identities? And I guess maybe even as a broader question, what does advocacy look like and how can we really address the stigma? So I'll open it up to all of you. Thank you.
Yeah, so I will start on that. So because I also traverse the mental health and working with persons also in the industry and different places, one of the things that I've found to be a major challenge is being able to be comfortable in our skin and in our spaces. So it is the affirmation that we offer to each other around the fact that you are who you are. And no matter what others think, that's who you are. There are certain things that you can't change, and there are certain things that you should not want to change. And the spaces in which you operate, you make choices to operate in those spaces. And so you attempt to make sure that you are so empowered. You are so, matter of fact, I've moved away from the concept of empowerment to enlightenment because empowerment assumes that somebody shares power with you or gives you power. Enlightenment suggests that that is coming from within you. So that self-understanding of your own capacity allows you to accept your skin and your space and whatever kind of contribution that you're going to make to society. I'll leave it there.
Um, I would say that advocacy has to come with justice. So the two go hand in hand. And if you're a healthcare practitioner and working with Black neurodiverse youth, that's the goal, that the mindset and the foundation of your interactions and communications are based on, that justice piece, that you're not just kind of passively being an advocate and have a full grasp of what that means. For many of the youth we work with, they're still discovering their identities. They're still figuring out what and when and where it's safe to be themselves. And so, yeah, from a healthcare practitioner's standpoint, it certainly is being willing to and understanding that advocacy is really about justice. It's not passive. It's very active. And so, creating those spaces where folks can reveal, share, and feel safe to do so is pretty paramount.
I guess I can try to respond briefly to the first part of the question around comfort. I think so. Most of the participants I spoke to live in Toronto. One of the challenges that we're having there is that there are fewer and fewer opportunities or like spaces for Black queer folks to gather, and so safely anyway. And so that's a challenge. And I mean, maybe part of the work that needs to be done is making like to carve out those spaces, in the wake of, gentrification, like condos everywhere and all of that. So we're losing a lot of great spaces to that. I guess the other thing that I was thinking about too around this question of comfort and, people feeling safe to express themselves has to do with, we're in a strange moment right now where there are ongoing attacks against queer and trans folks. And so there are some there's some like structural conditions that need to be addressed that are getting increasingly more difficult to fight against, it seems. So I guess I would say, advocacy groups, community organizations and stuff shouldn't or will need to keep, advocating with the government and other leaders and so on.
That's great. Thank you so much. So there's a couple questions as well in our chat here. So the first one, Danielle said, given the talks of the Human Rights Commission being discriminatory against people of color, and since a lot of the issues are indeed structural, provincial, federal, built-in legislation, how can we expect to advocate for and make meaningful change when the barriers are so barriers are rooted so deep? Sorry about that. Any commentary on that one?
Yeah, this is definitely an age-old question for a variety of oppressed, attacked, and excluded groups. From our perspective, as a community-based organization, we take the stance that we're gonna try to disrupt the areas of either social education or healthcare that we can. And we do so, collaboratively. So one thing is, using your community connections and using those community partnerships to either lobby or to take a stand or to bring awareness to or to make demands of the folks who have decision-making power. So that's one way. From a practice standpoint, within your own practice, you've got leeway to do assessments a certain way, approach people a certain way, provide documentation. So within your own practice, there certainly are ways that you can make a difference, and that you can, again, with the advocacy, really use a justice focus, use an intersectional approach, and use a justice focus to support your patients and to work with your patients. I do, unlike David, believe in self-empowerment, but I do agree that empowerment itself sounds like it is, I have the power and I'm giving it to you, which is very different from self-empowerment, which means as a healthcare practitioner, you're stepping out of the way. You are destroying, or you are, breaking down barriers in order to give folks the space, the time, and the capacity to self-advocate and to be self-empowered.
Thank you so much. So there was one other question there, but for the interest of time, I will just quickly summarize. It was considering kind of the notion of touch and thinking about that as kind of a therapeutic modality, and just questioning about that and about how we could think about that in terms of our treatment practices, for example. So I'm just I'll just leave it there for us, given the time constraints. But I do want to thank our speakers so much for joining us today. It was really, really interesting to learn about each of your research and interests in general. So thank you so much for sharing with us.
Thank you so much. This was wonderful. Thank you so
It
much.
was great to meet you all as well. So thank you.
All right. Take care.
Take care. Bye.
Bye.
Bye.